So we are going to talk about ultrasonography of the abdomen of small animals. First, for the abdominal ultrasound examination, it has to be first after a good clinical examination and eventual laboratory test that will guide us a bit about the pathology that we expect. We have to evaluate all the abdominal organs, so if they change in size, in shape and structures, and also to see if there is nodules or masses within the parenchyma of those organs. And we have to keep in mind that with abdominal ultrasonography, we can't get to a definitive diagnosis most of the time. Just with abdominal ultrasonography, we will need always fine needle aspirations or biopsies of those lesions or those organs to get a definitive diagnosis. So we will start with the ultrasonography of the liver. So the indications of the ultrasonography of the liver are multiple. We can do it because we feel an hepatomegaly on abdominal palpation, or we see it on abdominal radiography, because we palpate also a cranial abdominal mass. In case of jaundice, we have also to evaluate the liver, if we have increased liver enzymes, if we want to do a metastasis check, for example, if in a staging of a mastocytoma, in case of fever of unknown origin, if there is gastrointestinal signs, in case of PUPD, or if we want to aspirate or biopsy some lesions of the liver. So first, to perform an ultrasonography of the liver, we have to put the transducer caudal to the xiphoid process, and the probe will be directed cranially and dorsally. In that way, we will try to really observe all the liver from right to left and from ventral to dorsal. We can also perform an intercostal approach by putting the probe in between the ribs. That will be mostly for dogs with deep chest morphology, where the liver will be mostly situated behind the ribs and would be difficult to access just by putting the transducer caudal to the xiphoid. Then the liver, so a bit of anatomy, it's caudal to the diaphragm and cranial to the stomach, the spleen and the right kidney. So for the liver parenchyma, it has to be homogeneous. The liver edges will have sharp and pointy edges, meaning quite triangular. If they are getting rounded, it's already not normal. The echogenicity of the liver is in general the same as the one of the kidney. As we can see here on this image, we have quite the same echogenicity in between the liver and the right kidney. Sometimes the kidney is a bit less echogenic than the liver. And the spleen on the left side will be always more echoic, so more bright than the liver. So for the liver parenchyma, we can first observe diffuse changes. Mostly it will be increased echogenicity, hyperechogenic liver. So it will be brighter in general than the spleen or similar to the spleen. It's difficult, in fact, to assess those diffuse changes in echogenicity. Is quite subjective. But like here, we have an example of a diffuse hyperechoic liver, which is a bit increased in echogenicity. So this increased echogenicity can be due to different things. It can be due to lipidosis, fibrosis, lymphoma, or steroid-induced hepatopathy. Sometimes in some chronic hepatitis we can see that as well. With lipidosis, we will observe here, like in this case, an increased attenuation of the ultrasound beam. It means that the ultrasound beam is stopped quite strongly by this lipidotic liver, and in fact the liver is hyperechoic, and then it will become here darker in the most deepest part of the ultrasound image. It's just because there is this increased attenuation of the ultrasound beam. So that's quite typical of lipidosis. In those cases of lipidosis or with lymphoma, the liver will be increased in echogenicity, but also in general increased in size, also with steroid-induced hepatopathy. When, on the contrary, when there is a chronic hepatitis, we would expect to have more a decreased size of the liver. Then we can have also as a diffuse changes a diffuse decreased echogenicity of the liver parenchyma. So it will be less dark, less echogenic, so darker than the renal cortex. And we will have in fact what we call the increased visibility of the wall of the portal vessels that we can see here. So we can see here, for example, that all those portal vessels are definitely much more visible than normally. And here we have the edge of the liver that are a bit rounded, but definitely this liver is decreased in echogenicity. So the main causes of decreased echogenicity of the parenchyma of the liver are an acute hepatitis, congestion, lymphoma, and leukemia. That will be mostly what we can observe in those cases. And then, as a final diffuse change, we can have also diffuse heterogeneity of the liver. This is less common. We can see that with the chronic hepatitis, but also with the hepatocutaneous syndrome and some cases of neoplasia. So we have here an example where we can see a diffuse heterogeneity of the liver parenchyma with multiple hypoechoic areas dispersed throughout the parenchyma. In this case, it was just found as a vacuolar degeneration on aspiration, but in general we will find that with those causes here. Then the liver and parenchyma can also present some focal changes. So we can have focal anechoic lesions. Mostly it will be some small cysts like we can see here, or larger cysts like we can see in this image. So very anechoic cysts which create a distal acoustic enhancement. So it means that it's a bit more bright underneath the cyst than on the side of the cyst. So that's due in fact to a decreased attenuation of the ultrasound beam by the cyst because the fluid is not stopping the ultrasound. So mostly it will be because of cysts, but we can have some metastases that will look like cyst-like lesions, or necrotic areas or hematomas or abscess that will also be very anechoic on ultrasound. We can have also hypoechogenic lesions. So those hypoechoic lesions, like we can see here, we can have multiple differential for them. They can be either neoplastic, so metastasis, but also with some neoplasia such as lymphoma. We can also see that with nodular hyperplasia and sometimes some case again of necrosis or abscess. The problem of the ultrasound here is that it's not very specific to determine the cause of the hypoechoic nodules like that. So it's very sensitive because we see them very easily, but then it's difficult to differentiate just with ultrasound between malignant problem or between nodular hyperplasia, which is then very benign and without consequences for the dog. Finally, we get also hyperechogenic lesions. So in general, those lesions are mostly benign because they are often composed of fat or steroid hepatopathy. But we have to keep in mind that in some rare cases, like here, they can be also due to neoplasia or metastasis. Sometimes those hyperechoic lesions, like in this case, are just representing some mineralization, dystrophic mineralizations in the parenchyma, and then we see that there is an acoustic shadow underneath the lesion, which represents mineralizations because there is this attenuation of the ultrasound beam underneath the lesion. Then we have the mixed echogenic lesions. So mixed echogenic means that you can have either lesions with isoechoic and hypoechoic components like we have here. So here we have a round ovoid to ovoid lesion with some anechoic or hypoechoic cavities, but the rest of the lesion is isoechoic, or in this case as well. So mostly those mixed echoic lesions are representing neoplasia, but again they can be also benign if they are due to hematomas or abscess or nodular hyperplasia. So then, as a conclusion for those hepatic lesions, we always have to perform fine needle aspiration or biopsies to determine the origins of those focal lesions. Because on the base of the ultrasound examination, we cannot differentiate between benign and malignant lesions. Before we do that, we have, of course, to check the coagulation and the platelet counts of those animals. And we, of course, can perform those aspiration or biopsy under ultrasound guidance.